Welcome back for the first episode of Season 4 of the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. This is the first episode in our new format, which we hope you'll really enjoy. First of all, we're going to focus on infectious disease in children. You can expect to top up your knowledge and understand a little bit more about some differential diagnoses. After that, we'll be looking at the issue of healthcare inequalities, which is a subject that we think is really important. I'm Pat Anderson, editor of MIMS Learning, and with me in the studio today are my colleagues
Dawn Liz Powell.
And I'm Sangeeta Krishnan.
Thank you. So we're going to discuss a few modules that we have on childhood conditions. But first, let's touch on paediatric pertussis, or whooping cough, which is in the news at the time of recording this podcast. This is a cyclical condition with peaks every 3 to 5 years. And cases rose in the first part of 2024. Very sadly, there were 5 infant deaths between January and March, and I understand that it's babies who are most vulnerable. So it's important to ensure that everyone's vaccinated.
I assume the full course of vaccination gave you lifetime immunity, and if you had it once, you wouldn't get it again. Turns out that the full course doesn't grant full immunity, but the protection actually wears out over time. And if you do get whooping cough eventually, I believe it's characterized by a milder course.
To be honest, I was an adult before I realised whooping cough could be a serious condition. My mum was never worried about me or my sister getting it, but that's probably because we were both vaccinated, plus we were living in the UK in the 1980s with good access to healthcare, so childhood illnesses just wasn't something we needed to worry about.
Whooping cough was, I think, off the minds of the public for a while, but it's definitely back on the radar now, and I think it's connected to vaccine hesitancy. And that's a topic that the next episode in this series will cover with an interview with GP Dr. Farzana Hussain. As regards the symptoms of whooping cough that GPs should be looking out for, what do we know about that from our learning modules, Dawn?
According to a MIMS Learning clinical review, classical whooping cough often starts with a cold and catarrh. An irritant cough then develops, which worsens and becomes chronic. The cough can have the typical whoop sound, a protracted coughing spasm that ends with a sharp drawing of breath. The whoop, however, is often not present in older children, but the chronic cough can last for months. The whoop can also be absent in babies, particularly those younger than 3 months. And more concerning, in younger patients, apnea can often follow the cough or occur instead of the cough.
And if they are experiencing apnea, is that a distinguishing feature of whooping cough, or could it be something else?
Well, apnea in young children is rarely a sign of anything good and can actually indicate something even more serious than whooping cough. For example, apnea and respiratory distress can be a sign of sepsis or meningitis. They can also indicate bronchiolitis, pneumonia, or a seizure disorder.
And if a GP does encounter a suspected case of whooping cough, what action is recommended?
The first step is to alert the authorities, the local health protection team. The UK Health Security Agency says GPs should tell their local protection team about any suspected case of whooping cough. If appropriate, this team will then arrange an oral fluid test. GPs should also determine the vaccination history of young children who have been in recent close contact with the index case. If relevant, steps should then be taken to ensure these children are sufficiently vaccinated against whooping cough.
So what about management after that point?
For most patients, treatment of symptoms will be enough. While there is little evidence that treatment of symptoms affects the course of disease, antibiotics can help reduce nasal carriage and infectivity. Obviously, if a patient is seriously ill and requires hospitalisation, then much more intensive treatment is required. In terms of stopping the spread, official recommendations are that children with suspected whooping cough should not go to school or nursery for 48 hours after starting antibiotic therapy. However, if they're not on treatment, they should be kept away for 21 days after the onset of symptoms.
Gosh, that sounds like a long time. So thanks, Dawn. Useful to know about the up-to-date guidance. And let's turn to something else that GPs will see a lot of, and that's acute skin rashes, which may be the first manifestation of viral or bacterial illness. So we've got a learning module on this written by paediatric dermatology experts, Dr. Darshini Satishkumar and Dr. Helen Goodyear. And this is a really thorough module, isn't it, Sangeeta?
Yeah, it is. So the module covers a wide variety of causes of rash with a focus on infection. The rash may be the first manifestation of an illness that is accompanied by localized or generalized eruptions, and is often the most common reason for parents or patients to seek medical attention.
So presumably a GP would want to exclude red flags for conditions such as meningitis, first of all.
Yes, of course. So the red flag symptoms of erythematous rashes may include a fever of 38.5 degrees centigrade, tachycardia, tachypnea, reduced level of consciousness, delayed capillary refill, and hypertension. It's important to exclude conditions that require prompt intervention, like meningitis.
And what causes of rash does the module cover?
So the module covers an impressive range of causes. Something like 15 have been listed and described in good detail. Illnesses of viral origin include measles, rubella, roseola, infantum, erythema infectiosum, and chickenpox. Some viruses cause a distinct, well-recognized eruption, while others are more nonspecific. Some rashes have an underlying bacterial cause, like staphylococcal scalded skin syndrome and scarlet fever. There are rarer conditions like papular acrodermatitis of childhood or the Gianotti-Crosty syndrome, toxic shock syndrome, and drug-induced hypersensitivity syndrome.
Okay, so it must be quite a challenge for a GP to try and determine which on earth of those any given childhood rash might be. So in telling the difference between those causes, what are the key things to consider?
Yeah, so the first thing to do is to take history, which is quite important. History taking will include associated symptoms, whether the patient has traveled or otherwise been exposed to infection, current and previous medications they may be taking, social and recreational activities, and whether there are any existing systemic conditions. When examining the rash, you'd need to observe the lesion morphology, its distribution, the duration of, as in how long the patient has had the lesions, and a physical examination, including oral lesions.
Thanks, Sangeeta. So this is a really useful module, and it does have some images as well to aid identification of childhood rashes. Obviously, measles is also a concern in 2024, and we did discuss that in a previous podcast. And we also have some learning around measles, which is signposted through the links under this podcast episode.
Yeah, as you said, Pat, measles is very much still a concern according to data from Jan to April 2024 from the UK Health Security Agency. Measles has crossed 1,000 cases this year in the UK, and Kent is facing a measles emergency, reportedly with 3 times as many infections as seen in England.
Yes, and unfortunately, scarlet fever is also still circulating, and although it's lower than last year, it's still higher than average for the last 5 years, according to the UK Health Security Agency. Again, we have discussed scarlet fever previously, but we do also have a module about a rare but important complication of scarlet fever, which is invasive group A streptococcus. This is a quick, bite-sized module by GP Dr. Pipin Singh, and it just reminds GPs about the symptoms of GAS. There's apparently quite a broad range, and some of the first ones on the list are sore throat, fever, headaches, acute cough, otalgia, myalgia, and a blanching rash starting around the neck. Strawberry tongue may also be seen. Dr. Singh provides some useful tips on practical tools and prescribing, and one thing that I really liked was, in case tablets or capsules have to be used, in other words, if the liquid form of medicine is not available, there's a helpful recommendation from the Kids Med resource, which provides support to parents around pill swallowing. And I do remember this from childhood. I remember being pills crushed in jam, which was not good and has left me with mixed feelings around jam.
I wonder if the pills are going to be crushed with honey or something like that in the Kids Med resource. I would be curious to see what that's like.
This whole discussion makes me think about what my mum used to say when I was ill. Like if I had a cold or something, she'd always be going, "Oh, hot bath and early bed," and The annoying thing as an adult, you realise she was right.
Well, thank you, Dawn. Yeah, very true, very wise. So that's been a whistle-stop tour around just some of our learning around infectious disease in children. So what are our key takeaways from the discussion today? Dawn, would you like to go first?
If a GP suspects whooping cough, they should alert their local health authority. They should also determine the vaccination history of young children who have been in close contact with an index case, and ensure parents know how long they should keep children with whooping cough away from nursery or school.
Mine is that when evaluating a child presenting with a rash with a potentially infectious cause, GPs should take a detailed history and perform a careful examination of the rash, including its morphology and distribution.
I think my key takeaway is that there are a lot of differentials for these common respiratory and skin symptoms, so it's a real diagnostic challenge for GPs. Another thing we wanted to talk about today is health inequalities. Now, many GPs are, of course, very aware of the inequalities that exist in terms of health outcomes in different groups in society, and there are moves at a national and local level to address these. A lot of inequalities stem from deprivation. GPs can feel a little bit powerless to do anything about them. But MIMS Learning is running a campaign called Targeting Health Inequalities, which aims to provide some encouragement and support to GPs and other healthcare professionals. So I'm here with Rhiannon Ashman for this part of the podcast. Hi, Rhiannon.
Hi, Pat.
And I know that you were at our event, MIMS Learning Live in London, and perhaps having a few chats around health inequalities at that event.
Yeah, thank you. I did. I went to MIMS Learning Live London last week and I spoke to a lot of GPs, actually. Some really interesting conversations. But we're going to hear from one GP in particular in a minute, Dr. Ravi Ramanathan, who is our clinical advisor at MIMS Learning for Primary Care, about his experience of health inequalities in his patient population, what they're doing about it, why he thinks it's important.
So let's hear what Ravi had to say.
Hello, I'm Dr. Ravi Ramanathan. I work at Gordon House Surgery in Ealing, and I'm also the GP advisor to MIMS.
Thanks, Ravi. Great to speak to you at MIMS Learning Live. How are you enjoying the conference so far?
Yes, the conference is excellent as usual. I've gone to a variety of streams, all very interesting.
Great, glad to hear it. So you work in Ealing, obviously urban population.
Yes.
What are your kind of patient demographics?
So it's a very diverse population with quite a lot of morbidity and mortality, and also quite a varied demographic. I suppose it's a typical London population, and with varying degrees of deprivation as well, even within our practice area.
As you know, we're running this campaign about health inequalities, and clearly sort of social deprivation is a really big one. How do you find that impacts your practice day to day?
Okay, I mean, it's quite clear that there is a significant amount of inequality across different populations and the way that they access care and the care that's delivered. So it comes up again and again. Diabetic care is a classic example. Then you've got it in renal disease. We've been listening to that today. And also in areas such as screening too, there's significant differences across populations, and there's significant differences in the impact of those inequalities across those populations as well.
So certain people are impacted much more heavily.
Yes, and during the pandemic that was obviously highlighted, and after the pandemic in terms of chronic disease management is still extremely apparent.
So where would you say the key learning needs are around that? Are there any specific things you can pull out?
I think the key learning need is understanding that significant inequalities exist, and then I suppose the challenge is to create mechanisms to reduce these inequalities. There are various small projects starting currently. For instance, in our area, we're trying to target Afro-Caribbean men who've not had their blood pressure checked because their blood pressure is significantly less than the rest of the population.
Why would that be?
I mean, the reasons are extremely complex, but if you look at the figures, it definitely exists, and then that has a knock-on effect for cardiovascular disease, stroke, and so on. So we can't change societal situations, but we can address these inequalities where we identify them.
Exactly, and I think that with this health inequalities campaign, it's very much like, okay, GPs know it exists, they know their patient population, but what are the practical things that you can actually do?
Inequalities exist, they're massive in some areas, and if we want to take the health of the population as a whole seriously, then we need to start addressing these inequalities.
So that's really interesting to hear Ravi's comments. Do you think that increasingly GPs are talking about health inequalities?
Yeah, it seems to be something anecdotally that we're hearing a lot of GPs talking about now, much more so than maybe a few years ago. So it's definitely on people's radar. And as Ravi said, this is a big societal problem and we can't fix societal problems, but there are practical things that you can do. So I think this is really where the MIMS Learning Targeting Health Inequalities campaign comes in.
Yeah, so I think we're hoping that it might fill some learning gaps by providing practical tips of things that you can actually do in your practice and an opportunity to reflect on areas that you might not have thought about. Could you talk, Rhiannon, about a couple of examples of CPD that you've produced as part of the campaign?
Absolutely. I think you're right, Pat, that our GPs, our audience, are really good at knowing about their individual local populations and what's going on for them. And I think where our campaign comes into its own is that it can really maybe broaden your perspective and give you an opportunity to learn about some areas of health inequalities that you might not have had direct experience with or that you might not have thought about. I wrote a report recently based on the Embrace confidential inquiries into maternal mortality, which was fascinating and looked at the different experiences of white women compared with Black women and Asian women. And that gave some really good learning points, actually, that clinicians could take into their practice to try and address these inequalities. And we also published a module recently on prison healthcare, which, again, is probably not something that many people are dealing with on a day-to-day basis. But actually, the module, what it really highlighted is that it's very likely that you will come into contact with somebody who has been involved with the prison system, especially if you're working in primary care in the community, perhaps somebody that has recently come out of prison. If you're in secondary care, you might well be in contact with people who are still in the prison system, and you might be looking at discharging people back to prison. And so there were a lot of learning points there around what you need to consider. Some really fascinating learning on offer.
Yeah, I thought the prison healthcare learning was strong in that it talked about the chronic disease management and end of life care and just different aspects that it would be really interesting to think through. Absolutely. I don't want to just do a big list of everything that we've done in the healthcare inequalities campaign, but we have just published the second part of our transgender healthcare module, and that's to do with consultation skills around people who are questioning their gender identity or trying to access gender identity services. And really interesting reading, I think. And I think it's probably something we'll touch on again in subsequent podcasts.
We have done a previous podcast episode in the last series, didn't we, where we looked at the first part of this series on why transgender healthcare was important, and that was really well received.
It was, yeah, and that was setting the scene, and then the consultation skills one takes it forward a step further. So we've also produced a free PDF which highlights some of the learning we have on offer in the Health Inequalities campaign, and you can download this from the podcast notes on your podcast player. And do feel free to have a look at that PDF and share it with colleagues. It's free to share. And all the learning that's highlighted in the PDF is actually free to access with a free registration for healthcare professionals on MIMS Learning. So come and have a look, and we hope that we can support you. Thanks for joining us. In next week's episode, Rhiannon is chatting with Dr. Farzana Hossain about vaccine hesitancy. So do tune in then for some fascinating insights as to why different patient groups may be reluctant to get vaccinated and what GPs can do in their practice. Goodbye for now.